This is the second video in this series on calcium and phosphate disorders, and the specific topic is hypercalcemia. There are many clinical manifestations of hypercalcemia. Many medical students remember the symptoms from the saying, stones, bones, groans, and psychiatric overtones. To what do these terms refer? Stones refers to nephrolithiasis, bones is bone pain, groans is abdominal pain, and psychiatric overtones refers to any or all of depression, anxiety, and confusion. Other symptoms can include constipation, anorexia, nausea, weakness, and lethargy. When it comes to the physical exam, unfortunately, there are no reliable physical findings of hypercalcemia that are sensitive or specific enough to be useful in diagnosis. There are, however, some very interesting findings that can be seen on EKG. The classic finding is shown here. This is an example of an unusually short QT interval with a near absence of the ST segment, which lies between the QRS complex, or the sharp vertical spike, and the T wave, which is the rounder and broader wave that comes afterwards. Although there are a few very rare etiologies of a short QT interval, hypercalcemia is the only etiology that is remotely common. Here is a rarely described EKG finding in hypercalcemia. We can see that this patient has elevations of the ST segment, best seen in leads V1 through V3. These ST elevations can mimic an acute myocardial infarction, triggering an unnecessary trip to the cath lab or inappropriate administration of thrombolysis. Unfortunately, because this finding in hypercalcemia is several orders of magnitude less common than a true heart attack, depending on the exact details of the presentation, it may be impossible to identify the real cause before therapy is initiated for an MI. Finally, if one combines the short QT interval with ST segment elevation, one could imagine this being the result. In this case, we can see an unusual wave tacked onto the end of the QRS complex, most obvious in leads 1 and 2, but also in V3 through V6. This extra wave is called an Osborn wave and is usually associated with hypothermia. Beyond the symptoms and EKG findings, additional manifestations of hypercalcemia include dehydration, renal insufficiency, nephrogenic diabetes insipidus, in which the kidneys are inadequately responsive to the hormone ADH, and type 1 renal tubular acidosis, in which cells in the distal tubule are unable to excrete excess hydrogen ions, leading to a metabolic acidosis. Let's talk about the etiologies of hypercalcemia. If you watched my last video on normal calcium phosphate homeostasis, this diagram should look familiar. It will be of key importance in understanding the 5 basic mechanisms of hypercalcemia. First, remember that PTH is responsible for inhibiting bone formation, stimulating bone resorption, and stimulating renal absorption of filtered calcium. As a consequence, PTH excess would lead to hypercalcemia. This is, by a large margin, the most common general mechanism. The next most common general mechanism is bone resorption at a rate in excess of bone formation, which occurs independent of hormone direction. Next, since vitamin D acts similarly to PTH on calcium levels, excessive vitamin D can also lead to hypercalcemia. Excessive dietary intake of calcium can occasionally occur. And finally, thiazide diuretics lead to increased reabsorption of calcium in the kidneys. This is rarely a cause of clinically relevant hypercalcemia in itself, but can either unmask or worsen borderline hypercalcemia in patients with another etiology also present. So what are the specific conditions in each mechanistic category? In PTH excess, there is something called hyperparathyroidism, which is when one or more of the 4 parathyroid glands produces too much PTH due to a problem intrinsic to the parathyroid gland itself. Hyperparathyroidism can be categorized as primary, if the problem is just too much PTH coming from the glands. It can also be categorized as tertiary. Tertiary hyperparathyroidism is a tricky topic that I'll actually talk about in the next video when discussing secondary hyperparathyroidism, which can occur when renal failure leads to hypocalcemia. Regarding the specific causes of primary hyperparathyroidism, there are three. 90% of cases of primary hyperparathyroidism are caused by an adenoma, which is a benign growth in a single gland that produces PTH without regard to serum calcium levels. 5 to 10% of cases are caused by diffuse hyperplasia, in which all four glands are just larger than normal and thus collectively produce too much PTH, even when their responsiveness to PTH may be relatively normal. Finally, 1 to 5% of cases are caused by a malignant parathyroid carcinoma. Going back to the etiologies by mechanism, another cause of PTH excess is a malignancy that secretes a protein called PTHrP, which stands for parathyroid hormone-related protein, which shares most of the basic actions of PTH, with the exception that it does not stimulate 1-alpha hydroxylase and calcitriol production. Unfortunately, PTHrP is not subject to regulation by calcium, so calcium levels continue to climb without functioning negative feedback. This might seem like an unusual and random mechanism, but it's actually quite common. PTHrP is also a normally produced hormone, the exact function of which in normal physiology has not yet been fully worked out. Lithium therapy may increase the set point at which calcium suppresses PTH release. Finally, in this category is an autosomal dominant disorder called familial hypocalciuric hypercalcemia, which is characterized by decreased responsiveness of parathyroid cells to increased serum calcium, similar to the effect of lithium. Although this is a rare disorder, it's discussed on wards and shows up on exams a bit out of proportion to its rarity, not unlike many other rare genetic diseases. In the next category of etiologies, those causing hormone-independent bone resorption, most common are osteolytic bone metastases. There is also something called Paget's disease of bone, characterized by focally limited accelerated rates of bone remodeling, resulting in bony deformities, decreased bone integrity, and pain. Hyperthyroidism and immobilization are also both associated with increased bone resorption. Vitamin D excess can be caused by one of two situations. The first is obviously excessive intake of vitamin D. The second is ectopic production of calcitriol, which can occur in granulomatous disorders such as sarcoidosis and tuberculosis, as well as in lymphoma. Excessive dietary intake of calcium can result in the milk alkali syndrome. This is defined as the combination of hypercalcemia, metabolic alkalosis, and renal insufficiency. Historically, milk alkali syndrome first became prominent in the early 20th century after popularization of a regimen to treat peptic ulcer disease that consisted of milk and alkali salts such as sodium bicarbonate. After the development first of H2 blockers and then later on proton pump inhibitors, milk alkali syndrome became almost unheard of by the mid to late 1980s. However, with the increasing popularity of calcium carbonate to prevent osteoporosis, this syndrome has experienced a resurgence and is now the third most common cause of hypercalcemia after primary hyperparathyroidism and cancer. There's not much more to say about the thiazides. And finally, there are some rare miscellaneous causes that don't clearly fit into one of the other categories. Included here are adrenal crisis, severe rhabdomyolysis, particularly when complicated by acute kidney injury, and theophylline toxicity. In none of these potentially life-threatening problems will the hypercalcemia be the predominant physiologic issue. The combination of primary hyperparathyroidism, PTHrP secreting malignancy, and osteolytic bone metastases are collectively responsible for about 90% of all clinically relevant cases of hypercalcemia. I'm going to spend another minute talking specifically about hypercalcemia and malignancy. This is a common problem. Hypercalcemia complicates the course of 10 to 30% of all patients with cancer. As already mentioned, some cancers produce PTHrP, a condition specifically known as humoral hypercalcemia of malignancy. Cancers most likely to do this are lung, breast, ovarian, and renal cell carcinoma. Among patients with hypercalcemia complicating malignancy, this type makes up 80%. Osteolytic metastases can be seen in almost all cancers, but breast, lung, and multiple myeloma are at the highest risk. This makes up about 20% of cases. Finally, ectopic production of calcitriol, seen occasionally in lymphoma, Hodgkin's lymphoma more so than non-Hodgkin's lymphoma, is responsible for about 1% of cases. Overall, hypercalcemia complicating malignancy is a very poor prognostic factor that usually occurs very late in the course of the disease. Among patients diagnosed with this, only 50% will be alive at 1 month. Specific factors suggesting a better prognosis than this include young age, successful treatment of hypercalcemia, and ongoing active treatment of the underlying malignancy. When it comes to the diagnostic evaluation, the first step is to correct the calcium for low albumin. This will prevent you from underestimating the degree of hypercalcemia. Step 2 is to perform a thorough physical exam and obtain a chest x-ray. The combination of the exam and x-ray will likely discover any undiagnosed malignancy, as it would be at a late stage. Furthermore, it may help to identify some of the less common causes of hypercalcemia, such as hyperthyroidism, which can be picked up on exam, and sarcoidosis, which could be picked up on the x-ray or potentially the exam. The next step is to check a PTH level. There is a higher incidence of hyperparathyroidism among patients with malignancy, so therefore it's reasonable to check a PTH even in patients with a previously known cancer. This is particularly important given the substantial negative prognostic impact of hypercalcemia of malignancy. The PTH level is where the algorithm starts to diverge into two possibilities. In the first, the PTH level is either high or at the high end of normal. In this case, one would probably be safe assuming the patient had primary hyperparathyroidism. However, to be sure, you would measure a 24-hour urine calcium excretion. If it was high, your suspicion would be right. But if it was low, the patient actually would have familial hypocalciuric hypercalcemia. Going back to the PTH, if it was low or at the low end of normal, the next step would be to measure PTH-RP, calcidiol, and calcitriol. If PTH-RP is elevated, the patient has a malignancy. If the calcidiol is elevated, the patient has excessive dietary intake of vitamin D. If calcitriol is elevated but calcidiol is not, the patient has ectopic production of calcitriol. Finally, if none of the three are elevated, the patient may have bone mets, and if not, you should consider other rare causes. Since malignancy and primary hyperparathyroidism are the two most common etiologies, let me do a little comparing and contrasting. The symptoms of hypercalcemia in malignancy can be either mild or severe, but in hyperparathyroidism they are usually mild. Hypercalcemia from malignancy becomes symptomatic over days to weeks, while hyperparathyroidism is over weeks to months. The physical exam in malignancy is usually abnormal for some reason related to the cancer, while there are usually no overt physical manifestations of hyperparathyroidism. Malignancy is the most common etiology of hypercalcemia among inpatients, while primary hyperparathyroidism is the most common etiology of hypercalcemia among outpatients. Finally, the corrected serum calcium at the time of presentation is usually above 12.5 milligrams per deciliter in malignancy, and usually less than 12.5 in hyperparathyroidism. Last, we have treatment. The treatment of hypercalcemia has come a long way in just the past 10 to 15 years. Treatment options include hydration with normal saline, furosemide, bisphosphonates, calcitonin, steroids, and gallium nitrate. Usually, multiple interventions will be applied simultaneously, and the exact selection depends upon the underlying cause and severity. IV hydration is essential in most patients with symptomatic hypercalcemia due to polyuria. One should always use normal saline instead of lactated ringers due to the presence of calcium in the latter. The appropriate infusion rate of saline can be anywhere from 150 to 500 milliliters per hour until euvolemia is resolved. Only after a patient is euvolemic should furosemide be considered, which works by inhibiting calcium reabsorption in the distal tubule. The prior strategy of linking aggressive hydration beyond euvolemia with high-dose furosemide, which I can remember doing as an intern as recently as 10 years ago, has fallen out of favor due to established success with bisphosphonates. Bisphosphonates are pyrophosphate analogs that inhibit osteoclast-mediated bone resorption. They are generally very effective, but may be slightly less so in hypercalcemia due to PTHrP. Hypomagnesemia is a major risk factor for developing hypocalcemia in response to therapy. There are 4 specific bisphosphonates available in the US. My apologies to those viewers from other parts of the world, but I'm not familiar with exactly what's available where. Pamidronate is an IV infusion given over 2 to 24 hours, depending upon the specific protocol. Its indication is hypercalcemia. There are a number of side effects and toxicities, including flu-like symptoms, renal failure, which is rare, osteonecrosis of the jaw, and musculoskeletal pain. Risk factors for osteonecrosis of the jaw include poor dental hygiene and invasive dental procedures after treatment is initiated. Zoledronic acid is a 15-minute IV infusion available for hypercalcemia, osteoporosis, or Paget's disease. Its side effects are the same as for pamidronate. Although they are not typically used in the treatment of hypercalcemia, both alendronate and risedronate, which are oral medications, can be used for osteoporosis or Paget's disease. Side effects include musculoskeletal pain and esophagitis. The next treatment option is calcitonin. As you might remember from the last video, calcitonin prevents bone resorption, which it does by inhibiting osteoclasts. It can be administered either IM or sub-Q. It works quickly but has a relatively weak effect, and patients develop tachyphylaxis within 48 hours. There are few side effects. Steroids are only helpful in hypercalcemia due to ectopic production of calcitriol in lymphoma and granulomatous diseases. A typical dose is prednisone 10 to 40 milligrams daily. Finally is a simple compound called gallium nitrate. Its calcium-lowering effects were first noticed when patients who started off with normal calcium levels developed hypocalcemia after receiving gallium scans. Gallium inhibits bone resorption directly and may also inhibit PTH secretion. It's at least as effective as bisphosphonates, if not more so. But unfortunately, it requires a continuous 5-day infusion and carries the risk of nephrotoxicity. So here's a summary of the treatment options. Normal saline and furosemide start to lower the calcium within 1 to 2 hours, but the duration of effect is only during treatment. Saline's major side effect is obviously volume overload, while that of furosemide is additional electrolyte imbalances such as hypokalemia. Bisphosphonates work within 1 to 2 days, last 2 to 4 weeks with each treatment, and can cause acute kidney injury, osteonecrosis of the jaw, and musculoskeletal pain. Calcitonin works within 4 to 6 hours but lasts only 2 days. Steroids work within 2 to 4 days and their effect lasts several weeks. The side effects of steroids are the same as with any indication and include hyperglycemia and fluid retention. And finally, gallium nitrate works within 1 to 2 days, lasts 2 weeks, and has a major toxicity of acute kidney injury. That concludes this video on hypercalcemia. The next video will cover hypocalcemia.